everyone. Can you hear? Can you hear? Yeah. My name is Penny Wright. We're happy to have you all here tonight. We're always grateful to Stony Brook, Southampton for not only being in our community, but for having wonderful practitioners who are also willing to come here and speak to this community. So, Karen Wolfrat is here. She is responsible for this outreach, and we are grateful for that. This evening we're here, as you know, because you're here for that reason, to hear from Dr. John Reilly, who will talk about heart care. And I'll tell you a few things about him before we begin. He graduated from Columbia University's College of Physicians and Surgeons and trained in internal medicine at NYU Medical Center and Bellevue Hospital, where he was chief resident. He completed an advanced fellowship in interventional cardiology at Scripps Clinic in La Jolla, California. In 2002, he joined the Ochsner Medical Center in New Orleans, where he became vice chair of clinical affairs for the Department of Cardiology and medical director of the Cardiac Catheterization Laboratory for the entire medical system. In 2008, Dr. Reilly joined Stony Brook Cardiology and now practices as part of Stony Brook Cardiology and Specialty Care in Southampton. He is board certified in interventional cardiology, cardiovascular medicine, and has lectured nationally and internationally on cardiac disease treatment and prevention. He is a new East End resident and looks forward to bringing his experience and expertise to our community. It's a great honor to have him. Please welcome Dr. Reilly.
Thank you very much. I appreciate the introduction. It's very generous. Thanks all of you for your time and coming to listen to me. So I appreciate it. I have some familiar faces in the audience, and so welcome back. You heard me speak before. Welcome. Thank you very much for coming. So we will get started, and I hope to leave plenty of time for some questions at the end. As we said, I just moved up from Louisiana, which is down here in the dark blue. You don't get the dark blue it's not a blue ribbon, right? So this has ever been told you had angina or coronary heart disease, and almost 50%, or it's 4.3 to 6.5%, some of the highest percentage in the United States is right down here in the Gulf South. And that's because of the high rates of hypertension, tobacco use, lack of physical activity. When I give these presentations and I put this picture up for our residents and our fellows, I can ask the question, who is this person? And I get, that's not the answer that I get. Well, you're right, this is Dwight Eisenhower. Why is the cardiologist putting Dwight Eisenhower up during this talk?
Yeah, heart disease.
Not only a heart disease, he had specifically a heart attack while in office as a sitting president. Okay? Now the difference between heart disease during Eisenhower's term here in September 1955 when he had his heart attack is the treatment for having a heart attack in 1955 was take 2 weeks off, sit in bed, don't do anything, God forbid something should happen. Okay? Every 40 seconds an American has a heart attack. So it's very prevalent here in the United States. So what is a heart attack? Well, this is the EKG of a heart attack. And you can, if you're not familiar with looking at EKGs, but I will tell you that these ugly, jagged lines up here are the sign of somebody having a heart attack, what we call an anterior infarction. Grimly, we would refer to this change here in EKG as tombstone elevations in the anterior wall, because this signals a very proximal heart attack. So as opposed to poor President Eisenhower, today we know that the best treatment for someone having an acute heart attack is to come directly to the emergency department, and once there, to come directly to the cardiac cath lab and undergo a procedure to open up the artery. So this is an angiogram, and you may not have seen pictures of this before. This is the catheter coming up, in this case, from the femoral artery, just at your hip. It's threaded up over a wire, we engage it into the right coronary artery, inject some contrast dye through the catheter here in your hip. It gets injected into the artery, and it outlines this right coronary artery. In this case, this gentleman who presented with that EKG had a fairly normal looking right coronary artery. Now you look here and you say, well, this circumflex artery in the back wall of the heart, that just looks nice, just as nice and smooth and gently tapering as that right coronary artery you showed me. What's the problem here? The problem here is this little beak that looks like a dog's face or maybe a duck's nose or something here. That's the blunt occlusion of an LAD infarction, the LAD being the artery in the front wall of your heart. So through this catheter, we've advanced this thin wire. This is a very fine wire, it's 14,000ths of an inch in diameter. Okay? It's sitting here at the end of the artery. The balloon tracks over that wire to be direct, so we can steer the wire where we want to go. The balloon then follows the wire, and we inflate the balloon right where that beak was. And now you can see here, here's the shape, you can make out, here's the shape where that dog's nose was at the beginning, and it stopped right here. And this branch and all these branches down here were all missing from that angiogram. And that's what a heart attack is when the artery gets completely occluded and there's no flow moving downstream. So this is the placement of a stent, which is mounted on the balloon. It's crushed down, it's crimped down and closed on the balloon, and then once the balloon expands, it opens up and acts as scaffolding to prop that artery open and hold it up. You might see a little corrugation kind of at the top there. Those are the struts, the stent, holding that artery open. At the end, we did what we call a left ventriculogram, where we did put this catheter, it's called a pigtail catheter because it kind of looks like a cartoon Porky Pig's tail. And we inject contrast through that pigtail catheter into the ventricle. And this is the diastole, the phase where the heart's meant to be filling up with blood for the next heartbeat out, where it's going to pump out for the next beat. So this is the shape in diastole. It should all close together like the bellows, like a bellows at your fireplace. But here you see that all this part's closing in the way it's meant to. This part's closing in the way it's meant to. But that whole area here is sort of hanging still. It looks not that different from when it's meant to be filling and when it should be pumping and emptying out. Okay? That's because if you can imagine that artery I showed you where there was that blunt occlusion around here, and all these branches that came down here were closed, this area is all sort of stunned and not moving. And that's what's happening when someone has a heart attack. So these are the common cardiac risk factors that you're probably all familiar with. Blood pressure, cholesterol, good cholesterol, having diabetes or not, and whether you're a smoker or not. And the more of these, right, so the more of these you have, ideal blood pressure, the rest will be higher blood pressure, higher cholesterol, the higher your prevalence or likelihood for having a heart attack or heart disease. And it's true, and that's true for men and women, white or black, across the spectrum. There's nobody who's immune to coronary artery disease. And because that's important to see that, women are tracking right along with men. There has been historically this assumption that heart disease is a man's disease. But heart disease kills just as many women as men. So none of us are immune. Hospital discharge for coronary heart disease is getting better. It's not all bleak news, okay? We are reducing the number of heart attacks in this country over the last 20 years, since 1997 to 2014. So what do I do, right? Lots of people come into the office and say, what can I do? How do I stop it? I hear X. is the magic potion, right? This summer, maybe it was this spring, celery juice was like the be-all and end-all. That was the snake oil, that was the magic bean that Jack had, right? So, and they had all, celery juice was meant to cure all these claims about what could help you, what was fix everything that was ailing you. Right? Now it turns out that probably none of these were true about celery juice. Approximately 0 was the number of these claims that were true, and when you read the accounts of what who was touting this and why they were touting it, it was largely on the basis of anecdote, where they would have 2 or 3 people who would testify and say, I did this and my heartburn went away. I took celery juice and I can walk for it, right? Not large randomized trials where people were blind as to whether this was celery juice or something else that tasted equally awful and may not be beneficial. So just put the celery in the Bloody Mary. So blend it up, all right, and enjoy it. Okay. This, it's an unfair question, but for bonus points, does anybody know what this is meant to be? What this is?
Carrie.
It's, they sound like this is red yeast rice. Now, some of you may have heard about red yeast rice. And red yeast rice is maybe a potential replacement for people. People say, I want something natural. I don't want to take a statin. I don't want to take a cholesterol medicine. What can I take instead? And red yeast rice is one of the potential things that people might say, can I take that? It's natural instead of taking my statin. Does red yeast rice work? Yes, it does. It does help lower cholesterol. It does help improve your lab value numbers. Why does red yeast rice work? Well, red yeast rice, it's a fermented rice product, and in that fermentation, there's a chemical reaction. When you bake bread and yeast is forming, there's a chemical reaction. That's how you get the product raised of the bread. There's a chemical reaction going on here, and the chemical that's produced inside red yeast rice has the same structure as statin medication. And actually, the exact amount, and depending on which preparation of red yeast rice you go to the supplement store and purchase, how effective it is at lowering your cholesterol is dependent on how much of that statin-like chemical has been developed in there. So, yes, there are natural products that may be helpful in your health, whether it's cardiac or pulmonary or GI or whatever, but it's all chemistry. Our internal body is all kind of regulated by chemistry. And so, if it's going to be effective or not, it has to have a similar chemistry as maybe the pharmacist's prescription medication, or get through that mechanism in some similar way. So as I said, whatever proportion amount of this chemical that's in red yeast rice it has, that's how effective it will be compared to the statin. Is it equally effective as statin? No. But there's some people who can't tolerate the statin. I'm sure you know somebody who has, or maybe you've tried it before and it hasn't been successful. And red yeast rice might be a partial replacement for it. So life's simple 7 is the American Heart Association's guideline for 7 simple things for having a heart-healthy lifestyle. And there are things that we should probably, if we stop and think about it, we know, we might ignore, but we know what they are. We should be at an ideal body weight. Get plenty of exercise. Eat a good, healthy, balanced, varied diet. He's got his blood pressure cuff on. He's making sure he's got an ideal blood pressure. No smoking. Low sugar. diabetes is a very high risk factor for coronary artery disease. How bad is diabetes for your heart? Very, right, very. As bad as already having had a heart attack? Yes. If you have diabetes, your risk of having a heart attack in the next 5 years is similar to that of somebody who has already had a heart attack. So you should think of yourself as treating yourself just as aggressively as somebody as if you had already been told you had a heart attack. And then, of course, this ugly guy is LDL, the bad cholesterol, so having good cholesterol. So what percentage of Americans think that they have hit the targets on all 7 of these and have ideal cardiovascular risk? 15%. 15%? 39% of Americans surveyed think too many. And what percentage of Americans actually hit all 7 targets here for an ideal heart healthy diet, heart healthy lifestyle? 7 would have been very appropriate. 1% to check all 7 boxes. Okay, so that's not that good. Are the targets to hit difficult? Some are harder than others. So your BMI, your body mass index, and that's a function of height and weight. There's plenty of calculators you can find online or on to download to your phone. Just type in what your height is, and what your weight is, and tell you exactly what your BMI is. Okay, so that should be under 25. 30 minutes of moderate activity, 5 days a week. They're all on their bikes. They have to go pumping their way up the hill, mountain biking all the time? No. If you go for a 30-minute walk, 5 days a week, good. If you do yoga, great. The more you sit, the less good it is for you. Okay. So 30 minutes of moderate activity. 4 to 5 servings of fruits or vegetables daily. Daily. I heard some groans there. Your mommy told you. Less than 36 ounces of sugared drinks a week. A week. Right? So sweet tea, soft drinks, etc. 36 ounces. And that diet should have no fried foods, very little red meat, rare red meat, more fish, right? Particularly those cold water fishes like salmon and tuna that have those omega-3 fatty acids that are very heart healthy for you.
Just have a quick question.
Yes?
They've recently put chicken on that whole thing about just as bad as red meat. Have chicken.
Well, dark meat chicken, the dark meat has just as much saturated fat as red meat has. Chicken breast is still okay. Chicken, turkey, poultry breast is still okay. But all that thigh and wing and drumsticks has as much saturated fat as red meat does. And that's why the breast meat is so much dry. It's drier so much easier. It doesn't have the fat in there to protect it. An ideal blood pressure is less than 120/80. Okay, and a couple years ago, they actually lowered this target. Right? They used to make the definition for what is high blood pressure is 140/85. A couple years ago, they changed that definition. They said 130. Everything with the top number over 130 is borderline hypertensive. Okay, an ideal blood pressure is less than 120/80. Having never smoked is ideal. If you have smoked, if you've quit a year ago, that's good. So either that or that wipes the slate clean. Okay, and maybe not clean, but it's much better, right? So some people say, well, I've been a smoker. What's the point? I've smoked for 25 or 30 years. They can measure improvements in your pulmonary function tests, and in as short as a few weeks. Say, sometimes if you've had to have surgery, say, please just stop it for a few weeks before we have surgery. They can measure that difference. and at a year, you've significantly reduced your risk of heart disease. Your fasting glucose less than 100. If you've got diabetes, you want to have your sugar as well controlled as possible. Now, total cholesterol is less than 200. I will say that about cholesterol is these are guideline. This is kind of a guideline based on Western diets, okay, American, European diets. You kind of look at what's the average cholesterol for people, how high does it go, and where does the people who are at the highest risk fall, and it's at 200. If you see non-Western diet, people who have never seen a McDonald's, right? People who don't know what the Whopper is, and who've eaten a more Aboriginal type diet, much more closer to this their whole lives, their cholesterols are going to be in the 130s, 150s. Okay, that's probably where the human species average cholesterol is meant to be. But 200, we want to catch cholesterol below 200. Which brings me to the point about statins. I talked to you about Discharges.
Yeah, and what do you consider the ideal LDL?
LDL is the bad cholesterol, right? The low density lipoprotein. Lipoprotein, cholesterol is one of the lipoproteins. It's a combination molecule of fat and protein. And then they break them down further to the non-cholesterols, to those that have a lot of protein and a little bit of fat. That's high density. Protein's heavier than fat. Or LDL, the low density, that has a lot of fat, just a little bit of protein on that molecule. So the LDL is a bad cholesterol because more fat per molecule that can get deposited into these arteries. So what's ideal? LDL, if the total cholesterol is 200, the guideline would be for the general population who doesn't have heart disease, your LDL should be less than 130. Okay? Having a good cholesterol LDL will be less than 100. Now, for our patients who we know have heart disease, that gentleman at the beginning that I showed you had a heart attack, we put a stent in, we should hold him to a stricter standard than the rest of us, right? We should try to treat him more aggressively than the general population because we know he's got heart disease. So his goal LDL should be at least 70 or lower, but there's no number that's too low. And there's some people who are on cholesterol, say they've been on a cholesterol medicine, they've been taking their statin, the LDL is down, but they come in again and they've had a heart attack, and we see on their angiogram that they have had progression of disease. That they had some other moderate plaque 2 years ago, and now it's severe, and they need a new stent today, despite us being very cholesterol and they very aggressive about their cholesterol, and they've been, taking their medication every night. There's some IV medicines that are available now that will get people's LDLs down into the 20s. Okay? So, and they take that IV medicine once a month or once a quarter or something to help them out. Do I care really about what the cholesterol number is? When I pull up the lab sheet, do I care what your number is on the sheet? Or do I care that you don't have a heart attack and don't have a stroke and don't need a stent, don't need a bypass operation? That's really what we care about, right? Right? So that's what this chart's meant to convince you of. These are, what is it, about 10 studies here that were all done comparing people who are on a statin medicine versus being on a control, a placebo. They didn't know which one they were on, and then they looked at in each of these studies, who had a heart attack and who didn't have a heart attack, okay, in a randomized controlled manner. So then they take, and you see that some of the studies showed, here, this one, for example, being to this side favors being on a statin, and that favors the control of the placebo. Some of these studies, that point lies to the left blue line. That means it was better for the statin. Some of them, this broad line here crosses over, and that means it didn't mean one way or the other. So they do a meta-analysis. They take the data from all 10 of these studies together, and they combine them to get 32,000 patients. And say when we take 32,000 patients, got statin, another 4,000 patients, that, well, dyslexic there, 342, not 324. 34,000 of statin versus control, 70,000 people that said which end was better, and that is the roll-up of all that data together. It said you're about 70% is likely, 65% is likely to have a heart attack if you take a statin compared to if you don't take a statin. To me, that's the reason why I tell people to take a statin, not because to get their LDL, it was 101, now it's 99, so now you made the target, you made the benchmark. It used to be 80, and actually 65. I like to see that, I'm happy to see that it's working. I'm happy that we've hit that goal, right? But the real reason why I tell you to take the statin is to reduce your risk of having a heart attack. And it reduces your risk of having a cerebral vascular accident, it's a stroke. Okay? 70% risk of stroke. It's 70% risk of dying. Taking a statin compared to not taking a statin. Okay? Thank you. I'm just saying, great. See, you've done a terrible job giving this talk. If I made the assumption that everybody knows what a statin is, okay, I apologize for that. So a statin is a class of cholesterol medicines. There are several different classes of cholesterol medicines, but over 20 years since I graduated medical school, really the statin class is the predominant class for this, because of all this data. It's atorvastatin, which brand name is Lipitor, rosuvastatin, the brand name is Crestor, pravastatin, brand name is Pravachol. These are just some of the lovastatin. These are some of the cholesterol medicines. They all have a particular molecule in them, and each one they're slightly different, right? But they have a central common chunk to it. Qualifies it as a statin, right? Okay, that's sort of the chemistry. It's like alcohol. Right? There's a kind of molecule that is alcohol, but then there are other things that are adjusted to different flavors that makes it vodka or gin or bourbon or whatever, right? So there's a common chunk of the molecule that is a statin, and sometimes there are other attachments to it that make it more or less greater strength, okay? From pravastatin through to rosuvastatin.
Is it artificial?
It's a drug. It's a medication. Okay? Yes. I mean, it depends on what your definition of artificial is. I think I wouldn't call it artificial because
It's made in a lab.
it's made in a lab. It is made in a lab.
What's the side effects?
So what are the potential side effects from statins? I don't know if I have this. So some people who take statins, their sugar is raised. Is there a higher risk of having, is there a higher risk of actually being diagnosed with diabetes on a statin compared to not? This same meta-analysis that I've been showing you shows that it's not. That's the same risk there. The most common complaint people have about being on a statin is myalgia, muscle ache. Okay? Some people start taking it and they get muscle aches to the point where they want to stop taking it. Probably 15 or 20% of people have enough myalgia on statin that they want to stop taking it. Okay? In terms of how many, if we did biopsies, we did blood tests to measure how is it measurable inflammation in the muscle or not, that's actually more like 5%. But there's about 15 or 20% of people who say, I can't take it. Now, they may not have that reaction to every one of those statin medications. If atorvastatin caused it, maybe they can tolerate rosuvastatin. They might be able to tolerate pravastatin. And they may have to try and work through this.
All right, so when you're talking about statins, if you have a problem, what do you advise as far as milligrams?
So depending on what at the beginning I showed you the case of the guy who has an angiogram, right? They had the angiogram because he had the heart attack. He's a high-risk patient, right? He's already demonstrated he's had heart disease, he's got known plaque, and he's had a heart attack. He's high risk, so we have to treat him the most aggressively. So we put him on what we call high-intensity statin, which would be 80 milligrams of atorvastatin, Lipitor, or 40 milligrams of rosuvastatin, which is Crestor. Okay? Now, if someone who is has a moderate risk, their cholesterol is sort of borderline 200, they have no known heart disease, maybe they used to smoke and they have a family history, and so then maybe we would suggest they should go on a moderate intensity cholesterol medicine. Then they might take somewhere between 20 and 40 milligrams of atorvastatin, maybe 10 milligrams of rosuvastatin. So the people who are at the highest risk should get the most intense therapy. And the broader population, where we're just trying to prevent something that hasn't happened yet, and they're at kind of an intermediate risk, they get a more moderate level of risk reduction. Now for the general population who maybe have high cholesterol, but they don't have something else, like high blood pressure or diabetes or used to smoke, that puts them at high risk. We're not going to straight off the bat tell them that they have to take 80 milligrams of the medication. We're going to tell them to follow the heart healthy lifestyle, follow that heart healthy diet I told you up front, exercise as much as possible. Does that answer your question?
Thank you.
Can I ask
Yep.
people who have individual questions about dosages and situations that might refer to them to wait until afterwards for those
Sure.
kinds of questions? Okay.
Okay, so I showed you already the blood pressure of 120 over 80. I do want to mention quickly about blood pressure. Blood pressure affects 1 in 3 Americans. So that's just almost as prevalent as coronary heart disease itself. It's one of the most common underlying risk factors for heart attacks and strokes. This paper is from the 30s. And this surgeon, in the 1930s, they were doing an operation called sympathectomy, which meant an open laparotomy, abdominal surgery. They open up your abdomen. They went alongside your spine, the nerves that are coming out of the spinal cord there, and clipped them to separate all the nerves that are around your kidneys, specifically, and your intestines, to separate them cut them off from your spinal cord to keep the sympathetic system. The sympathetic system is like the nervous system portion of adrenaline, right? You're familiar with adrenaline, that kind of sudden fight or flight response. And the people who had the sympathectomy had lower blood pressure than the people who didn't. And the worse your blood pressure is, the greater your benefit you got from it. And the worse your blood pressure is, in yellow, the less likely you're going to survive 5 years. Look, if you had really the most severe class of hypertension, this is in the 1930s, they're only 10 or 20% of them are going to survive 5 years. Okay? We didn't have all the medications to treat high blood pressure then that we do now. So that fell out of favor because of the complication of that surgery. But today, we're investigating, doing research into a device that we put inside the kidney arteries that applies some energy along those sympathetic nerves that kind of create that same effect the surgeons were creating, apply that energy to zap these nerves that are running alongside parallel to the kidney artery. And this is the device that sort of centers it in the artery. This transducer emits ultrasound energy. You may have heard of some people who have kidney stones.
Yes.
They get ultrasound to zap them, and you say, that's just sound waves, how are they doing that? Same thing. These engineers are brilliant. They play with the amplitude and the energy of the transducer, and they can target exactly 6 millimeters of vessel in diameter, and heat that artery up, cauterize those nerves, and try and disconnect the sympathetic nervous system here. You see that people had dropped their office blood pressure about 25 millimeters. And an ambulatory blood pressure, which is kind of a, all throughout the day, almost 10 millimeters. And so this is a study that is still ongoing, looking how good a job can we do at a one-time treatment for blood pressure in a procedure similar to the angiogram I showed you before.
That's non-invasive.
That is an invasive procedure.
It's invasive.
It is. This is your kidney.
Yeah.
This is your aorta. So there's a catheter inside your aorta, same way like in the angiogram I showed you before. Instead of going up to your heart, it stops here at the kidney, and the catheter gets directed inside the kidney artery. So it is an invasive procedure, and the risk is similar to the risks of doing an angiogram of your heart. And in a similar way, your carotid arteries also help manage your blood pressure. It's got to protect your brain from getting too much blood pressure. And this is a stent-like device. You can see how small it is at somebody's fingers holding that device. To implant that into one side of the carotid artery in an invasive procedure, instead of going to the kidney arteries, this is seeing whether manipulating the carotid body here in your carotid artery. And in patients who got this device, these are the blood pressure reductions, systolic and dark blue, and the bottom number diastolic and light blue, over 1.5 years. About a 30 millimeter drop in their systolic blood pressure. These are for people who are on 3 drugs. And that's an example of the angiogram, and you make out the device after the angiogram. So I mentioned those because we're still investigating other ways to treat high blood pressure in addition to medications, because, as I said, 1 in 3 Americans have high blood pressure. A third of those people don't know they have high blood pressure and aren't getting treated at all. Of the people who are getting treated, about 1/3 are not meeting their goals for getting their blood pressure under 130, which is why we're sort of looking to other possible treatments for it. I like that information about hypertension, but it's easy for remember, third. I always get it right. All right, now can I open the floor to any questions?
Back on that slide with the meta-analysis.
Yes.
Could you just clarify, was the reduction for stroke, you use a number around 70%?
71, yep.
Was that reducing likelihood of a stroke or reducing?
Those are reducing the actual number of strokes that happened. Okay? So there were 34,000 people in the study who had who got statin. Another 34,000 who had the placebo. And so if whatever the event rate was, let's make it easy. Let's say there were 1,000 strokes in the control group. Okay, 1,000 out of 34,000 had a stroke. Only 710 in the statin group would have had a stroke. That's still a lot of strokes, but would you rather be in the group that had 1,000? 1,000 of you are going to have it, or only 700? So, well, I don't want to be in either one of those groups, right? If it was a mirror, it would be even better. It would be even better. And actually, those medications, these PCSK9 inhibitors, I haven't incorporated into this yet. They're just used much less frequently. That is an intravenous. It's a liquid, right? It's an injectable, and people go and get that once a month, or once every few months, as either a replacement or in addition to their statin medication. And I told you that's the medicine that can get people's LDLs down into the 20s, and their risk reduction is even greater than this. It's not getting the event rate down to 30% maybe, but greater than the 70%. Yes, sir.
If you're on a statin medication, how does your diet, can you change your diet? Does it have to be strict if you're on a statin medication?
So, ideally, right, my doctor had on, ideally, yes. You should still follow a heart healthy diet and take your statin. I mean, the question is, your question is, I'm taking this medicine to reduce my risk. Do I want to get all the benefit out of taking this medicine, or only part of the benefit out of taking this medicine? Right? To get all the benefit out of the medication, you should take it while eating a very heart healthy diet. Okay? I realize, taking off the hat, people are going to cheat. They find it hard to find a heart healthy diet. They find it hard to change a whole lifetime of habits, right? And it's not just diet, right? It's exercise, it's, it's movement, it's all those things, right? But if we're talking about how much benefit am I going to get out of this, right? You would, you would do both. You would continue doing both. You shouldn't like pop a lip or have a double bacon cheese.
The alternative to the pill statin that you mentioned, the injection, is that the medication that is not covered by Medicare, and it's about $12,000 a shot?
It's a very expensive medication. You're right. I meant to mention that when I was talking about. It's a very expensive medication because, right? Why isn't everybody taking that? It's expensive medication. You have to move through a lot of trying justification to why you should take that, or aren't you taking something cheaper like Pravastatin.
And also related, most people are placed on a generic statin, not Lipitor, but a generic statin. And there's been some studies or some anecdotal stuff that it's not as good. Is that?
I think the FDA does a pretty good job of making sure that if there's a generic, if they allow a generic to be available, it has just as much active component of atorvastatin that's inside that pill that Lipitor has. That's a natural history of drugs, as you know. The drugs on as a brand, as long as they have their trade through their patent, then it becomes generic.
What about aspirin? Is that,
Aspirin, thank you very much. Aspirin for primary prevention, meaning if you've never had a heart attack, never had a bypass, never had a stent, aspirin is no longer kind of recommended to widely advise it for everybody just for primary prevention. But if you have coronary artery disease, or if you've had a stroke, if you have a reason why you should be on it, you definitely should still be on it. Yes?
What do you think about the calcium score test in evaluating heart disease?
So the coronary calcium score, for those of you who do not know, coronary calcium score is a pretty quick and easy, it's definitely a painless, non-invasive test that you can have done. Insurance companies generally don't cover it. Most radiology departments offer it for around $100, somewhere between $80 and $140, depending on where in the country you live. You lay down the CAT scan machine, which is not particularly claustrophobic. The tunnel is only about that wide, the barrel. You lay it on the table. It goes in, there's X-ray exposure. That's the only risk to it. And it comes out and tells you your coronary artery calcium score is blah. You want blah to equal 0. Okay? So as we become less young, and we get calcium gets deposited into our joints and ligaments, and we develop stiffening or arthritis. But as part of the plaque deposition, calcium gets deposited into the plaque in our arteries or our aorta. And the computer on the CT scan is able to count up exactly how much calcium is there. And the higher your coronary calcium score is, the more your plaque burden. So it's an easy, non-invasive way of seeing how much plaque you have on board. And the more plaque you have, the greater your risk of having a heart attack. Okay? So I think the cardiac health score is a very good score for people who are at the intermediate risk, okay? It's all about kind of figuring out what risk people are in. So people who are already, we know they're at high risk. Unrepentant smoker, diabetic, BMI of 30, and hypertensive with a high cholesterol. That person's high risk. They should be eating, they should be coming as close to vegetarian as they can. They should be taking their statin medicine. They should start exercising and losing weight. That'll be the cardiac health score to help that person. 40-year-old woman, marathoner, regular exercise, their total cholesterol is 160. That person's low risk, and I probably don't need a cardiac health score to help them. The people who are at the intermediate risk, if their calcium score ends up being 0, I can now say, you're a low risk over the next, your risk of an event in the next 10 years is pretty low. But if your calcium score is high, then we bump you back up into the high risk category, and we start wagging your finger at the people and saying, get up off your bottom, go walk, go get some vegetables. So yeah, the cardiac calcium score is a very good score, very good test.
Does a statin reduce plaque? I mean, maybe your edge plaque will help reduce plaque.
Is it Drano? Will it take it out?
Even a little?
Yeah, a little, yes. Okay? Yeah, you were the one who was going to be greedy and say 70% was enough, I think it's down to 30%. Right, so yes, there will be some reduction, okay? And they have done some studies where when we do the angiograms and put an ultrasound catheter, an imaging catheter inside the artery and look at it from the inside out and say, well, we can measure the volume of plaque that's there and say, well, we took this artery that had maybe a 50% plaque and we gave them intense statin medicine and we got a relative 10% reduction, okay? And like a sale, 10% reduction sounds really good until you get to the counter and they say $30 and it's still $27, so that's almost the same thing. Right? So you get a 50% plaque and they might reduce it to a 45% stenosis. So that 5% difference is a 10% relative reduction. So yes, it can improve it. If that's satisfying to you, yes, that is. I think that when most people ask me that question, want me to hear, yes, I've got a 50% blockage, and if I take my medicine every single day, 2 years, put me back on that table, do another angiogram, and tell me that it's 10% or 0, and we don't have that. Okay? We don't have that.
Is there any other symptoms, like I just went and got a cardiovascular report,
Yeah.
and they got my cholesterol at 240, and they said don't worry about it, it was okay. But the thing that bothered me is they said this was connected to it, hypothyroid, and I didn't understand the connection at
Okay.
all.
So I'm happy, why don't we talk about specifically about you, just for after. I will say generally, thyroid, if you're not familiar, thyroid helps control our metabolism, right? If you're hyperthyroid, if your thyroid's too active, it sort of just revs everything up. And we get you're more prone to be hot in a warm room, you're more likely to be sweating, you'll probably tend to lose weight, and you'll burning off lots of energy. But if you are hypothyroid, the opposite happens. You're more likely to be sleepy, you're more likely to be cold in a cold room, in a cooler room when nobody else is, you're more likely to gain weight. And less likely to not metabolizing things as well. And so when that happens, our cholesterol levels tend to go up when we're hypothyroid because our liver and everything else is part of the metabolism of digestion and cholesterol metabolism isn't working as fast as everything else, and our cholesterol tends to go up. Yes?
What is that enzyme they said it is hyper, if you have a heart attack, TR something, TB something?
Are we talking about the cardiac enzymes that we draw in the emergency department when people have come in with trying to figure us out with it? Yes. Okay, TR something. Okay. So the muscle, the cardiac muscle, the mechanism by which all muscles contract, is sort of it's a ratcheting. event, okay? There's myosin and troponin. And the myosin grabs onto the troponin, and just sort of ratchets it. When it's time to shorten the muscle, the ratchet just sort of, and when it relaxes, it just sort of lets go, okay? And when we have a heart attack and the cells get injured, well, those proteins, the myosin and the troponin, they get spilled out when the cell opens up and breaks open. So the troponin floats into our bloodstream. And so when someone comes into the emergency department and we're trying to figure out, did this person have a heart attack or not, it's kind of hard to tell what their symptoms are. The EKG is not as clear-cut as the first EKG I showed you. We measure the blood tests and say, oh, the troponin's up. The heart muscles definitely had some injury, otherwise it wouldn't let troponin escape because it needs it to beat all day long. And so the troponin is a cardiac enzyme, protein, and another word for protein, it gets elevated. And we draw them in a series because, you know, if I have a heart attack right now, God forbid, it will take time for troponin to get circulated out into my bloodstream. So if I had a heart attack and you drew my blood level now, it should still be 0. But in 3 or 6 hours from now, we'll have had time to circulate and get around my body, and you can see it, which is why you come to the emergency department and say, well, we're going to admit you for observation. I'm going to draw troponins, a series of troponins over the next several hours. Yes?
Since we're on the topic regarding lab tests, how significant, when the blood chemistry is done, would be C-reactive protein in homocysteine?
Advanced level, next level question. Great question. Okay, so C-reactive protein is a marker of inflammation. And I've been talking mostly about cholesterol, plaque, and blockage, like the kitchen sink. Like, is there there's a plumbing problem, and it is a plumbing problem, but plaque does not grow like my fingernails or my hair or the lawn, where I know in X amount of time it's going to grow X amount. It is much more similar to getting a pimple before your wedding. And suddenly you're fine. All of a sudden there's some eruption and inflammation that goes along with plaque rupture. So, and C-reactive protein is a measurement of that inflammation. And so one of the benefits of, aside from the fact that typical American diets with lots of fried foods and red meat and saturated fat, etc., have lots of fat and cholesterol in them, is that they are very pro-oxidative and likely to lead toward a lot of inflammation. To make it more likely for the 50% plaque that you have that has been stable there for 10 years to undergo what we call an ulceration and a plaque rupture and inflammation. But then suddenly jumps from, it doesn't go incrementally from 50 to 51 to 52. It's 50, has this ulceration, and becomes a 60 or 70% plaque. And so that if we can lower your C-reactive protein, homocysteine similar, that's more to do with how cholesterol is metabolized, but also it is also a comment on your inflammation. If you can suppress that inflammation, that would be helpful. Part of the benefit of aspirin is on inflammation, although it is principally keeps the platelets from sticking together, the clot on top of the plaque. But statins also have anti-inflammatory properties, which is part of the reason why they help prevent events, in addition to just lowering cholesterol levels. Okay? I want to be respectful for the people who want to get out of here, and if anybody who maybe we can, Penny, you want to wrap it up now?
Sure.
I'm happy to go on, but I want to be respectful of people who need to get out of here or.
Maybe you'll stay for a few minutes.
I'm happy to stay for questions. I can turn my back so I don't feel guilty when we leave on this.
Before we say goodbye to some of you, just wanted to mention that Karen brought with her a bunch of things over there to take a look at, to take home, to pay attention to before you leave. But also, since some of you may leave, I want to thank Dr. Reilly so much for being here. It was most important.